Hi everyone, today's talk is going to be about upper GI bleeding. I'm going to talk about variceal bleed in particular, and this talk is geared towards medical students who are preparing for their exams or are due to soon start clinical practice. So I'm going to talk about the general principles, the basic principles involved in the assessment and management of upper GI bleeding, and how to approach the patient with the confirmed or suspected variceal bleed. It is very important before I start to understand that the management of significant bleeds, of massive upper GI bleeds is a team sport. Okay, this is not something that an individual can manage on their own and requires close cooperation and collaboration between emergency department teams, medical teams, nursing teams, gastroenterologists, endoscopists, critical care teams, and sometimes interventional radiologists and surgeons. So this is something which quite often requires teamwork and collaboration so that you can achieve the best outcome for your patient. Now, especially when we're talking about large volume bleeds, especially when we're talking about patients who are really unwell with an upper GI bleed, it is very important to have a very structured approach to these patients, just because in the heat of the situation you want to maintain a cool head. You have a set pro forma in your mind of how to approach this patient so that you can do all the things necessary and in the right order. So I'm going to talk about only variceal bleed in this particular lecture, and this is by no means an exhaustive lecture. This is just a general overview. Okay, so the initial assessment of the patient with the upper GI bleed. So the correct way to assess these patients and the easiest way to assess them is through the ABCDE pathway. This is what I use in my clinical practice and provides you a structured overview of things that you need to look for in an unwell patient. So we start with airway, the A part. So usually in these patients, you're not having to concentrate on the airway. Most of these patients are kind of awake, able to maintain their airway, but there will be a subset of patients who will have reduced GCS. This is because either they've lost a huge amount of blood, or they're known to have liver cirrhosis. They have hepatic encephalopathy, which again can cause a drop in the GCS. And if the GCS is very low, this can impair their ability to protect their own airway, and therefore they might have problems maintaining their airway. But usually, for most patients, you'll not have any trouble. They won't have any trouble with their airway. Similarly, for breathing, again, in most patients, this will not be an issue, but occasionally you will get the patient who is having hematemesis, a lot of vomiting, and might have aspirated, and therefore can have trouble with the breathing. They may have a high respiratory rate, reduced oxygen saturations. Even really unwell patients without having any actual breathing problems due to just their metabolic drive may have high respiratory rate. Third is the most important. Circulation is the most important part of the assessment in GI bleed, and this is what will quite often be impaired in patients with significant bleeds. Okay, so things to look for in circulation are the heart rate, blood pressure, and capillary refill time, the CRT. Okay, On the heart rate, you're looking for tachycardia. With regards to the blood pressure, you're looking for hypotension in these patients. Both of these indicate give you an indication that they've been actually losing quite a bit of blood. And you look for capillary refill time. The usual capillary refill time is less than 2 seconds, and the more the capillary refill time, the more the sort of indication that they are peripherally hypoperfused because of the GI blood loss. Okay, so heart rate, blood pressure. You can also make an assessment of postural hypotension, the lying or sitting blood pressure. But these two things are probably the most important in your assessment of these patients. Disability, again, I don't think in this particular situation you need to worry about any disability or neurological problems. And exposure, again, nothing much, but very occasionally you see people with melena who have had melena and are not able to communicate that to you. And when you expose these patients, you'll be able to see, you'll be able to realize that they've had a big bleed or a melena. So this is the initial assessment of these patients, and always have a structured approach to your assessment. Always do it in a set format. This is not just for upper GI bleed patients. This is for any patient who is really unwell. And yeah, always assess them using a structured ABCD approach, which will make your assessment quite methodical. Now, in a real life situation, you want to not only assess but start treating at the same time, because these patients are unwell and they need something doing quickly. So you want to do this in parallel to each other. So you don't want to just do an assessment and then hop over treatment. You want to do this side by side. Okay, so the important things is with regards to the circulation, while you're doing the assessment, you want to start giving some therapy at the same time. So very important is IV access. You want to be in a situation where if you need to give them a lot of blood products or intravenous fluids, you want to have good wide bore IV access. So 2 cannulas in the antecubital fossa is what is minimum recommended IV access. So green cannula and wider green cannula and bigger cannulas, so that you can push in fluids, blood products if need be at a quick pace. When you're putting in the IV access, at the same time also take some blood tests. So the blood tests you should be taking initially is the group and save, just because you're anticipating your need of requiring and having the requirement to give a blood transfusion or other blood products. Full blood count, very important, will tell you what the hemoglobin is. Urea and electrolyte, again very important, will tell you what electrolyte abnormalities that need to be corrected. What is the renal function, you will know with this blood test. Clotting is very important. So clotting, that is the PT and the INR. Now this may be deranged in people with liver disease, just because of the reduction in the production of the synthetic clotting factors, because the liver is not functioning well. And this might also be deranged in people who are on anticoagulation for some reason, say they're on warfarin or a direct anticoagulant agent. So clotting is very important. Liver enzymes, you can send at the same time. You'll be able to see if there's any what the level of derangement of liver enzymes is. Probably in the acute phase, it might not be that very useful, but send it regardless. And a venous blood gas. So nowadays, in many emergency departments, you will have the facility to quickly get a venous blood gas, and this is a very good tool, because the venous blood gas results are usually available pretty quickly in a few minutes. So in a few minutes, you'll be able to make an assessment of what actually the hemoglobin is, what are the electrolytes, what is the acid base status. So always get a venous gas if the patient has come through the emergency department, because the other blood tests would take some time, half an hour to an hour, uh, to get back. But venous gas, the result you'll have in a few minutes. Now we put your cannula in. You sent all these tests, and in the initial phase, you want your patient is unwell, they are hypotensive, they are tachycardic, and you want to give them some fluid resuscitation. And initially, you do that using crystalloids. So the sort of end goal is to replace blood with blood. So whatever blood they've lost, you want to replace it with blood products. But you just sent your blood test, you just sent your group, and say it will take some time before the blood reaches. The lab has to then prepare the blood and send it to you. So in the initial phase, go for IV crystalloids, and in the initial phase you'll be giving them in a form of a bolus with continuous assessment of their fluid status, of their heart rate and blood pressure. And then comes the role of blood products. So you want to give blood products because in principle whatever blood they've lost, you want to replace it with blood itself. Now what with regards to targets, with regards to correction of hemoglobin, so hemoglobin is important parameter that you will be monitoring, and you will need to correct the hemoglobin using red cells in case where there is a fall in hemoglobin. For most patients, the accepted target is around 70 to 80 grams per deciliter of hemoglobin. Now this is called a restrictive transfusion strategy, but studies have shown that this is enough in most cases. You don't need to transfuse someone more than this target in most cases. In some cases, like say if they've got ischemic heart disease, a higher target may be used, but it all depends on the clinical situation. But in most people, 70 to 80 is your target. It should be sufficient. Now, if your patient has been on, say, any anticoagulation, like say they've been on warfarin or they've been on direct anticoagulant, you will have to consider, especially in large volume bleeds, you will have to consider giving them a reversal agent, like say for example vitamin K in case of warfarin, prothrombic complex concentrate again in case of warfarin with major bleeds, or with direct anticoagulants, or a specific reversal agent if available for a specific direct anticoagulant. But you will need to consider the need on a case-to-case basis, and feel free to take the advice of specialists like hematologists if available at your institution to advise you on what reversal agent you should be using. Then comes the role of terlipressin. So terlipressin is a splanchnic vasoconstrictor, specifically recommended for the use of variceal GI bleeds. What it does is, because of splanchnic vasoconstriction, reduces the amount of bleeding. Now this is a reasonably safe drug in most cases, but beware of using it in people with known ischemic heart disease, as it can cause cardiac ischemia. So again, consider its use on a case-to-case basis and on risk-benefit ratio. Antibiotics is something that is commonly used in variceal bleeds, and this is because few studies in the past, studies and meta-analysis in the past has shown that use of broad-spectrum antibiotics in patients with variceal bleed reduces the risk of systemic bacteremia and infections. And as of now, most guidelines recommend giving broad-spectrum antibiotics. Your own institution will have its own policy of what antibiotic choice to use for variceal bleeds. But yeah, antibiotics at the moment recommended by most institutions and in most guidelines, with the thought that it reduces the risk of systemic bacteremia. And once you have done all of these steps, these steps, the assessment as well as the initial treatment, we can label as resuscitation. Now, I cannot emphasize enough the importance of initial resuscitation in patients with variceal bleed. You have to do all these steps just to make sure that your patient is in an optimal state before they go for endoscopy. Okay, so always resuscitate first and resuscitate well before you send the patient for endoscopy. So after you've finished this step, you give a call to the gastroenterologist, to your endoscopist, and discuss with them the need for upper GI endoscopy. Now, depending on the severity of the bleed, the endoscopy might have to be done then versus endoscopy within 24 hours. Again, depending on the severity of the bleed, this may be safe to do in the endoscopy unit itself, or it might have to be done in, say, the intensive care unit or in theaters with anesthetic team support. Upper GI endoscopy has a proven role in treatment of variceal bleed. The specific endotherapy that can be given for GI bleeds, variceal bleeds. So endotherapy may include something called variceal ligation, variceal banding, where a band is applied to esophageal varices, and if the varix is in the stomach, they might have to have a treatment which is called variceal gluing, where they inject a specific chemical substance which glues the varix and stops it from bleeding. So endotherapy is pretty good and will be successful in the majority of the patients who have come in with variceal bleed. However, it will not be successful in stopping the bleeding in all patients. So it is very important to have a post endoscopy plan and a rebleed strategy, because you want to plan, you always want to be one step ahead. You want to plan ahead. You want to think about the possibilities of what to do if the endoscopy is unsuccessful, or endoscopy is partly successful, or endoscopy is successful in the initial phase but the patient still has a rebleed. If the patient does have a rebleed, one of the options that might have to be considered in patients with varices, variceal bleed, a massive variceal bleed, is something called TIPS. So TIPS is a procedure where a portosystemic shunt is made via a percutaneous approach. This is done by interventional radiologists, and this is a procedure which is, where catheters pass through the groin, and a sort of connection is made between the portal system and the systemic circulation, with the aim to reduce the pressure in the portal system and therefore help with bleeding. Now, with regards to suitability of this procedure, is something that you will, the team members involved in the care of the patient will have to decide, because this procedure is not feasible or suitable in all patients. but this may be one of the options that might have to be considered in such patients. Um, so this is where I'm going to end this short lectures, this short talk on variceal bleeds. And the takeaway points are, again, variceal bleed, treatment of variceal bleed, treatment of the really unwell patients is a team sport, um, and requires close collaboration between various medical and nursing teams. To always have a structured approach. The ABCDE approach is a good structured approach for evaluation of such patients, and in a difficult time press situation, it will allow you to do a quick but comprehensive assessment of the patient. Third point is that resuscitation is key. Um, your IV fluids, blood products, correction of coagulopathy, reversal of coagulation in patients or an anticoagulation, terlipressin if patient is suitable, antibiotics. All of these are very important, and are to be done first before sending the patient to endoscopy. And then fourth point is, when they do go for endoscopy, you always have to plan ahead and make a comprehensive rebleed strategy as to what to do if endoscopy is unsuccessful, or they have a rebleed even after some endoscopic intervention. So this is where I'm going to conclude my talk. Hope you found this lecture useful, and hope you find it useful for your day-to-day practice.